Now, allow me to start our discussion with the opening talk on the burden of disease with Prof. AlJedai. Dr. AlJedai, تفضل. Prof. Ahmed AlJedai is the founding president of Saudi Society of Clinical Pharmacy, professor at Al Faisal University, and editor of the Saudi Journal of Clinical Pharmacy. Please welcome Dr. AlJedai.
سعادتكم جميعا وأسعد الله صباحكم في هذا الملتقى لنلتقي معكم حقيقة بالتعاون مع الزملاء في الجمعية السعودية لهشاشة العظام. Special thanks to the Saudi Society of Osteoporosis, represented by their chairman, the president, Prof. Riyad Suleimani. So thank you very much. This is one of the activities where we collaborate with industry and other societies to promote the well-being and care of our patients in different disease states. So I'm not an expert in osteoporosis by any means, but I know a lot about burden of diseases and burden of illness. So I'm gonna talk to you about the burden of disease when it comes to osteoporosis, which I consider, to be honest, a forgotten disease, a disease that many of the healthcare providers, including frontliner primary care, GPs, family medicine, they overlook when evaluating a patient, despite the increased prevalence that we see here and generally speaking in the world. So let's start with the conflict of interest. I don't have anything to disclose regarding this presentation, and I will not be discussing any off-label use of medications. So basically, I'm not going to lecture you on osteoporosis, but osteoporosis, as you all know, is defined as a low bone mineral density caused by altered bone microstructure. There are multiple risk factors. Again, we've heard some of them. Old age comes first, post-menopause. Some medication can cause it, endocrine and nutritional disorders, and some inflammatory arthropathies and other risk factors, such as obesity as well. You know, there are multiple where we get different types of osteoporosis, and I'm not here to talk to you about this. I'm here actually to talk to you about what this disease constitutes in terms of healthcare burden, society burden, and economic burden. So we've heard 1/3 of the women and 1/5 of men of age 50 and above will suffer from osteoporotic fracture globally. And if you look at the increased risk with time, between 1990 and projected to until 2050, hip fractures is estimated to increase by 310% in men and 240% in women. And I cannot tell you what hip fracture complications are, the increased risk of mortality post-hip fracture in elderly patients. As we speak, one fracture in every 3 seconds happen, unfortunately, with 8.3 million fractures occur annually. Approximately 80% of the people who had at least one of the osteoporotic fractures were neither treated nor identified. And this is the issue. The main issue we have is identifying those patients, taking care of them, preventing their fracture, and managing fracture if it happens. Only 1/3 of the vertebral fractures comes to clinical attention. This is really interesting when I learned this after searching the topic. You know, 2/3 of patients, they don't seek medical or they don't have access to appropriate medical care. Osteoporosis is the world's most common bone disease, affecting around 200 million people globally. If you look at 50% of women with osteoporosis typically begins after the age of 50. And this is very closely related to the demographics as well as the hormonal changes that happen post-menopausal. We know that osteoporosis come or occur in elderly patients more often. However, and in women post-menopausal more often. However, also men above the age of 50 will suffer osteoporosis as well. If you look at the age factor, we have an issue typically after we hit the age of 50, which is becoming now not really an old age. If we are talking about an average life expectancy in Saudi Arabia of 80 years by 2030, then 50 years is not really an old age. Despite this, we see increased risk of bone osteoporosis as well as bone fractures above this age. Now let's take a global burden of disease. And North America, we have an estimated 10 million people above the age of 50 years and older who have osteoporosis. And in Canada, for example, we have about 2.3 million living with osteoporosis. Let's look at Europe. The total number of Europeans with osteoporosis is around 10 million as we speak now. In Asia, and this is very interesting, more than 50% of the fractures that occur globally occur in Asia. There must be many reasons, including aging population as well. Now, Africa has an issue as well with osteoporosis because most of the African countries with low socioeconomic status, they end up having osteoporosis, not identified, having fractures not managed appropriately. Now, when we switch gears to the economic burden, we look at the European Union, for example, and this is really a staggering number. Around 57 billion euros annually are spent either on the prevention or management of osteoporosis or its complications, including fractures. The average direct cost of osteoporosis fracture was €109 for each individual. Osteoporosis in United States costs around 19 billion US dollars with all of its medical costs. We're not talking about the indirect costs related to, missing on job opportunities, staying home, taking all of the other non-medical costs, and wasting working days. However, it's projected that by 2025 in the United States, more than 3 million cases of osteoporosis fractures will occur per year, which is going to cost around 25 billion US dollars every year just to take care of those patients. Now, the projected costs in health care systems in China, just for the osteoporotic fracture by 2020 until 2040, were estimated to be around 13 billion US dollars and 22 billion respectively. If we look at 5 countries, and this is based on a recent published study, that compared the economic burden between 5 different countries, US, Australia, Germany, Spain, and South Korea, we can see, if we look at the average cost with each intervention, including the cost of care, the total medical cost, the total pharmacy and medications cost, total inpatient admission costs, and the total ER costs, with the total outpatient visits cost. you can see that for in each country, we're talking between 1.2, which means 120, 2%, up to 3.4 or 3.7 actually times, so 370% times the cost of those patients with osteoporosis compared to those patients with osteoporotic fracture. So once the patient develops an osteoporotic fracture, in other words, the cost of care, the overall cost of care rises between 120% to 370%. Now, there are other burden of illness other than the economic, other than the healthcare burden. We have what we call the humanistic burden of osteoporosis, which includes, these are some of the humanistic burden: physical disability and pain. And that's something that cannot be quantified into dollar values when you ask the patient. However, we can now, with the publication of the EuroQL EQ5D5L, which I'm happy to announce that it's going to come out very soon. It has been already accepted here in Saudi Arabia. We can estimate the health status and quantify this in dollars value and link it to the quality of life for those patients who are suffering from physical disability and pain. There are also psychological impacts related to the fracture that they have, staying home, not interacting with the community and society. The reduction in quality of life, as we all know, because the patient doesn't, in terms of their daily activities, are affected significantly, which affects their physical status and psychological status, and eventually result in reduction of their quality of life. And then we have the social isolation, as we talked about. There is a study looked at the humanistic burden of osteoporosis patients in the United States in Medicare patients, and looked at multiple aspects, including but not limited to the pain intensity, functional status, racial disparities. And overall, despite the improvement in these aspects, the overall humanistic burden remains significant in those patients who developed osteoporosis, and even worse in those patients who develop osteoporotic fractures. Now, what about MENA? What about our region? So these are the numbers from different countries in the region. We'll start with Egypt, where we have about 22 of men and up to 28% of women who have osteoporosis. In Lebanon, about 70% of elderly Lebanese patients had osteoporosis. UAE, we have in 2016, the prevalence of osteoporosis was about 3.1, and this is related to the demographics of the United Arab Emirates, having more younger population, expatriates who are on the work-life span. And then we have in Turkey, for example, around 1.3 million fragility fractures are predicted to occur every year in Turkey. And in Algeria, we have around 36% of the female adult patients suffering from osteoporosis. We're not that far, as we heard just a few minutes ago, from these numbers and from this burden. The prevalence of osteoporosis in the Middle East in females and MENA region, as you can see here in the map, the darker the color, the highest prevalence. So look at Turkey, one of the highest populated areas or countries in the region where they have highest prevalence of osteoporosis. Saudi Arabia and Algeria come next. Now, there are multiple risk factors. I'm not going to talk to you about them in details, but there are some genetics, age, family history of osteoporosis, and gender, definitely, and these are non-modifiable risk factors. The modifiable risk factors, however, we can work on them to prevent osteoporosis, reduce the incidence of osteoporosis, and assure the proper access of patients who are diagnosed with early stages of osteoporosis to receive the appropriate care. Socioeconomic status of the patient has been shown that, the lower socioeconomic, the higher risk of osteoporosis and osteoporosis-related fractures. Menopause and parity, we know menopause contributes significantly to the development of osteoporosis. Parity, nulliparity has been shown to correlate higher with the prevalence of osteoporosis. So having more kids actually delays the incidence or the development of osteoporosis. Finally, nutrition and lifestyle modifications, which are very important. Now, when we look at the osteoporosis in Saudi Arabia, the majority or the mortality rate in Saudi Arabia is about 27% within 1 year following a hip fracture. And that's what worries me a lot, because one of the things that we really need to do is work on prevention rather than management, because once you develop hip fracture as an elderly patient, you have around 1/3 or 30% risk of dying within a year. Now, another thing, we have about 175,000 new fragility fractures in 2019 based on a recent study. And this means that we have around 500 fractures every day with 20 fractures per hour. So if you care about targeting those patients, then we can actually reduce this. Now, one of the things is, people don't talk about this a lot, is that osteoporosis is actually directly related to one of our KPIs in Vision 2030, which is increasing the average life expectancy. If we can prevent more hip fractures, if we can prevent osteoporosis in those elderly patients, then we can significantly improve their lifespan. The average cost of osteoporosis management, the incremental cost per year, is around $9,000. We're talking about, 35,000 Saudi riyals, with about 635 million United States dollars spent in 2009 to spent on the total burden of osteoporosis-related fractures. Around 300 million US dollars were spent inside hospitals. Half of that was spent on testing. 86 million were spent on surgical costs, and 131 million for prescriptive medications. So I think we have a lot to do to improve the care of our patients by spending, more time, effort, and money on awareness campaigns, on prevention strategies, as well as on early intervention and management with appropriate therapy. If you look at the estimated number of fractures among adults age 50 to 90 in Saudi Arabia, you can see that the number in 2009 was about 27,000 for vertebral fractures, reached about 35,000. Cut the breast, for example, hip, and other fractures. So we have around 27 or 28% increase in number of fractures, osteoporotic fractures, between 2019 and 2023. These are scary numbers, because we're not doing a good job at preventing these fractures and managing them as well. Now, when it comes to factors influencing osteoporosis in Saudi Arabia, the rate of fragility, fracture, low rates of diagnosis, inadequate post-fracture care services, especially in rural and peripheral areas, and aging population. Despite that, we are a young population, but one of our targets by 2030 is to increase the life expectancy, which means that the sector of elderly going from 3.5% as we speak now, those above the age of 65, is going to actually increase to double, actually more than double, to reach about 7.5% of the total population, which means we're going to have more elderly, which means that we're going to have more fractures, more osteoporosis and more fractures, unless we start our national effort to reduce these statistics. One of the issues we have is the low diagnosis rate, and I know that Ministry of Health has worked on a national program for conducting a DEXA scan for those patients with high risk of developing osteoporosis and fractures, and we're going to hear about this hopefully today from our colleagues in the ministry. Post-fracture care services, unfortunately, we don't have access to surgical management in all regions, especially in small cities where we do not have trained orthopedic surgeons. We have issues with lifestyle modifications and physical activity in this part of the world, not only in Saudi Arabia, but as you all know, one of the issues we have is the non-communicable diseases, which is closely related to the lifestyle and physical activity. Dietary factors, cultural practices, and sun exposure. You know, we hide from sun all the time. Vitamin D intake is another issues. And then we have genetic predisposition that makes certain groups in Saudi Arabia more prone to osteoporosis and fracture. Now, the aging population, as I mentioned, we're going to reach about 7.5 or 8% by 2050. And this is going to increase the population of elderly patients who are more prone to osteoporosis. Now, with this, I end my talk, and I ask everybody today to engage in the discussions that we're going to have on prevention and management strategies. We're going to hear from experts, and I will be happy to answer any questions during the session break. Thank you.